Hello, you are listening to the Charles Bonnet Syndrome podcast. My name is Shaimond, and today's special guest is Dr. Andrew G. Lee. He is a medical doctor. He is also the Herb and Jene Lyman Centennial Chair of Ophthalmology at Blanton Eye Institute, Houston Methodist Hospital. How are you doing today, Dr. Lee?
Hello. Thanks for having me.
Thanks so much for being here today. And I want to say that I actually found Dr. Lee on YouTube. When I was doing research about Charles Bonnet Syndrome, he came up, and it was so good to be able to hear some medical doctors speak about this condition because from my experience, some doctors either don't know about it or don't speak about it. So if you don't mind, can you first start by telling the audience a little bit about what you do, the type of doctor you are, and a little bit of your background first?
Sure. I'm a neuro-ophthalmologist, which means I deal with vision problems related to neurologic or systemic disorders. And so Charles Bonnet Syndrome is completely within my wheelhouse, and it's something that we see all the time. And in my work as a clinician, patients who have vision loss and hallucinations, like the Charles Bonnet Syndrome, are the kind of patient that I see every day.
When did you first find out about Charles Bonnet Syndrome?
So the Charles Bonnet Syndrome, as many of your listeners probably already know, is named for Charles Bonnet, but he didn't have it. It was his grandfather who had it. And so it's been around for a long time because Charles Bonnet is a name from the past. And almost all ophthalmologists know about it as a syndrome and by the eponym Charles Bonnet. And so as a resident, you get to hear about this when you're in training.
Why do you think many doctors don't talk about it?
It is a sad reality of the Charles Bonnet syndrome that neither the patient nor the doctor wants to talk about it. The patient doesn't want to talk about it because they sometimes think it's a sign that they might be going crazy or that they're demented, when in reality, it's just a byproduct of the vision loss. And there's a certain stigma associated with depression and mental illness, not just in our country, but across the globe. And so patients feel like they don't want to tell their doctor about it. And then from the doctor side, it's lack of awareness that a hallucination, which is sometimes a sign of being on drugs like hallucinogens or a true sign of mental illness, is actually an organic finding in patients with vision loss. So I think it would be ignorance on the part of the doctors, but fear on the part of the patients that is preventing people from talking about it.
Are there any things that you can do to help your patients through this journey, like things maybe you can suggest or potential medical breakthroughs or something that you can maybe share?
Yes. So the first step is having awareness. So I'm grateful for the opportunity to be on your podcast and talk about Charles Bonnet, because the more people that know about the condition, it improves awareness that it is not a sign of people being crazy or telling a fib or being on drugs. So the first step is just awareness. And many patients with Charles Bonnet just feel better knowing that fact, knowing that they're not crazy, knowing that it's not going to blind them more. It's just a side effect of the vision loss they already have. And from the doctor's side, it's important for you to disseminate this information in the podcast so that doctors know that they have a role for patients. Even if there's no cure for Charles Bonnet, sometimes the treatment is just helping them to understand what it is. So a disease that has no cure doesn't mean nothing can be done. In fact, a disease that has no cure should definitely have things done about it, because the things that we can do are give hope and reassurance, and that is how we help patients with the Charles Bonnet. Recently, however, there's been some evidence that there are things that people can do, and many patients just figure this out on their own, that once they have the awareness that it's not going to harm them, some patients are actually amused by it, or they learn to ignore it, or by staring at it or staring away from it, the Charles Bonnet hallucination, they can make it more tolerable or even go away.
I actually interviewed someone recently who has Charles Bonnet, and she actually enjoys her Charles Bonnet. So I said that I was actually grateful that I was able to speak with her and she was able to share that, because the vast majority of people that I come across that have Charles Bonnet syndrome don't like it. And as a matter of fact, they're actually frightened by it and very frustrated by it. So I think it's good to know that some people can potentially enjoy it. And I think I really think that seems to be the key. Like you said, the vast majority of people, once they realize that they don't have dementia or that there is a condition called Charles Bonnet syndrome and they meet that criteria and ruled everything else out, they can deal with it. The thing that gets to be a little bit challenging for me as a caregiver and for other people, specifically people that have the condition, is when you fall into that like 33% where it's really frustrating, it's really turned their life upside down. Those are the people that it's really difficult for.
Yes, so many patients, as you noted, either ignore the image or are even amused by the image. But for that subset of patients where the images are disturbing, either because the image itself is disturbing or the idea of it is disturbing, those patients probably would benefit from keeping a diary to identify the triggers and also countermeasures that they might deploy, such as better lighting or just closing their eyes. Closing the eyes sometimes makes it better and makes it go away, especially if the vision loss is worse in one or the other eye. Removing the stimulus from the more damaged eye sometimes makes people better symptomatically. And we have a lot of patients who use non-Western, non-pharmacologic countermeasures, meditation, mindfulness, eye movement directed behavioral therapy. But for the subset that you described where the patients are actually disturbed by the images, there is probably a role for anxiolytic therapy and sleep hygiene, stress reduction, and cognitive behavioral therapy, the traditional therapies that we use for anxiety related to disease processes in other diseases, not just in Charles Bonnet. So one of the things that I hope your podcast will do is to reach physicians to know that even though there's no cure for Charles Bonnet, there are treatments. And one of the best treatments is just letting Charles Bonnet patients interact with each other and hear from each other. And that is a patient support process that is not usually accessed by doctors. And so it's really important that Charles Bonnet people know they're not alone and that there are other people who have overcome their disability through various Western and non-Western pharmacologic and non-pharmacologic means.
I really like what you said about the diary, because what I say to people that have Charles Bonnet syndrome is that you may not be able to control the hallucination, but you can control how you respond to it. And I don't want to seem like I'm not caring or empathetic, because I actually don't have Charles Bonnet syndrome. But that really is like a hard fact until some kind of a drug or some kind of treatment is really available. I hear that it's cathartic, it's therapeutic to be able to write down how you feel. And if you're not comfortable writing, or you maybe don't have enough vision to write in the traditional sense, you can dictate it. And it's been proven that having a diary can help in many different ways with how you feel, regulating your emotions, setting goals, or whatever it is. So I think that's really important, what you said about that.
Yes, and I agree completely that patients want to have a sense of control. And by writing it down and addressing their feelings about Charles Bonnet to themselves, it gives them a sense of control. And I think that having the diary can also document things that make me better, things that make me worse, things that I can do to help myself, because those things are all individual and sometimes idiosyncratic. I have patients who swear by certain measures that they do, whether it's having a cup of coffee or a glass of tea or just meditating, where they can literally will it away. And that sense of control is very interesting to me from a psychologic standpoint, but it's also helpful to patients to gain back control of their lives, especially for that subset of patients where it's disturbing to them because they don't feel they have control.
This is so interesting too, because Charles Bonnet seems to be so different for so many people. And I think that can be one of the challenges. The one universal thing is the visual impairment. You have to have that. But aside from that, it seems to be some people like them, some people don't. Some people, once they find out that it is Charles Bonnet, they can deal with it. Some people can't. Some people wear an eye patch and it works. Some people wear an eye patch and it doesn't. I've even heard people tell me that they wear an eye patch and they don't have the hallucinations. And I say, well, that's great, because for some people, they're present all the time with an eye patch or not. But then I've heard this from more than one person. They said with the eye patch on, they don't feel comfortable because they don't know what's happening around them. And I said, that's an interesting statement because they know that the Charles Bonnet syndrome hallucinations are not real, but they're having a difficult time trying to wrap their minds about the whole thing, that really there's nothing there outside of them, but you got to let them do what feels comfortable to them. Change is a process, but that's an interesting statement. So in that particular instance, the person can actually find relief, but they don't feel comfortable using that method because of what they think. Do you have any insight into why that could be? I know that could get into maybe a psychological thing, but I'm just curious.
Yes, I think people's responses to disease vary. So it's similar to the stages of grief for loss of a loved one or perhaps some other life stressor like divorce or losing your job. You really have to go through the whole cycle. And Dr. Kubler-Ross described this for a grief cycle where people are initially in denial, and then they have anger, and then they get depressed about it. And then there's this bargaining phase where people slowly figure out what they can and cannot do, and then acceptance. So going through that entire cycle is an important psychological journey. And for doctors, we have to recognize which part of the cycle the patient is in to provide the appropriate intervention. So understanding is the first step in terms of moving from denial and out of anger. And then the depression phase needs counseling, and that phase benefits most from Western pharmacologic, antidepressant, and anxiolytic therapy. And then slowly moving towards bargaining, which means intervening in diary, changes in lifestyle, exercise, and finally to acceptance. And so helping the patient through the entire Kubler-Ross cycle is a really important role for physicians, and just helping the patient as they make that journey is an important role for the doctors.
Can you talk a little bit about the anxiolytic therapy? I've never really heard that term.
Sure. So lytic, it means break. Anxio is anxiety. So there are many medicines that we use to break anxiety, and they have a number of different names. And the most prominent class is called benzodiazepines. So we don't want to give drugs to people who might be susceptible to worsening of their hallucinations, but a whole range of drugs have been used in patients in various stages of the response to the Charles Bonnet. And so if someone's truly anxious about their condition or their symptoms, anxiolytics are the therapy that we use for that anxiety. Of course, it doesn't fix the Charles Bonnet, but it fixes or at least helps to mitigate the psychological response during that depression phase of the full Kubler-Ross cycle. Once you move into the acceptance phase, then you can taper down or maybe even get rid of these drugs. And there is some risk, of course, to adding drugs onto patients with the Bonnet. And as you probably have spoken to other researchers, just adding or subtracting medicines can make people with the Bonnet better.
I've heard that. And as a matter of fact, before you even say that you have Charles Bonnet syndrome, you're actually supposed to go through various different tests, talk to your primary care physician. They may refer you to other doctors because they want to rule out other things. They want to figure out what kind of drugs they're taking because some drugs can help you, can make you hallucinate. They want to do some kind of test. Sometimes they even do brain scans and make sure that you don't have dementia or something. And those are very important things to rule out. The people that I've come across, they actually say that it actually seems from their doctor's perspective that they do have Charles Bonnet syndrome. And unfortunately, sometimes you can't even get an official diagnosis because doctors are unfamiliar with Charles Bonnet syndrome and don't really give you that official diagnosis.
Yes, I think that's one of the most important parts of your podcast is that patients need to be advocates for themselves, not only to educate themselves, but to also educate their doctors about Charles Bonnet.
I just want to commend you for taking the time to talk about the condition. I've had people tell me that they think I may be stigmatized just for having this podcast. And it's just their frustration or anxiety about Charles Bonnet syndrome. And we were even wondering if certain doctors aren't willing to discuss it because of maybe the fact that they might be stigmatized or something. I don't know if we're like going out on a limb there, but I commend you for the fact of just talking about it. And if there weren't people like yourself or others, whether they're advocates or whatever, then we wouldn't even know about this condition.
I think that's exactly right. Your podcast has two target audiences. One is patients and their families, and the other is providers. And I think there is a stigma to talking about things that have no treatment. So doctors went into medicine because they wanted to cure diseases. And so as soon as you get into the mindset that there's no cure, then you want to dismiss the patient. And so helping physicians understand that their role is not just disease diagnose, treat, but also disease diagnose, treat, educate, and help people navigate even uncurable disorders like Charles Bonnet is also part of our job.
It seems like in my experience, because I go to I've probably been on hundreds of Charles Bonnet syndrome support groups. And it seems that when people really want to control the hallucinations, or maybe they want to understand why, or they might forceful, or they're very frustrated, it seems to actually backfire and make the hallucinations worse. And it seems, if at all possible, trying to accept it and realizing what's happening and not trying to say it's something else. Because I've heard people say that it's spirits and don't look people in their eyes or something. And it seems like if you can try to maybe accept it and not try to fight it or force it, it might even be a little bit more helpful to you.
So there are basically two strategies for dealing with the Charles Bonnet. One is adaptation and habituation. And adaptation and habituation usually means understanding first and then slowly figuring out your psychological response to the hallucinations. And that is a superior strategy. But some people have chosen the alternative strategy, which is avoidance about thinking about it, avoidance about trying to accept it, and moving towards these alternative explanations, as you say. That is the denial phase. So I think that what you've said is spot on in terms of people's attitudes towards the Charles Bonnet, and that sometimes focusing too much on it actually makes it worse. And so we really have two strategies: avoidance, which is a difficult thing to do, and adaptation and habituation. Adaptation and habituation is a better strategy, just getting used to and adapting to the hallucination. And in some patients, incorporating that hallucination into their activities and just saying, here's the Charles Bonnet coming, actually helps them with the acceptance phase.
And I find that people that have Charles Bonnet syndrome more often than not feel stigmatized and they don't really want to talk about it. And I can understand, because hallucinations has a negative connotation, just the word hallucination. But what I do find is the small percentage of people that become advocates and they talk about it as much with anybody that they're around, I find that's more beneficial for them, because they're not trying to keep secrets and not trying to shy away from things. And then by talking about something, you feel better. And then when you can explain it, people start to realize, okay, this is a real thing. And another thing that happens is when people start talking about it in small groups, large groups, somebody says, well, you know what? My aunt had a visual impairment and she was hallucinating and I didn't realize that. Or somebody themselves might say, you know what? I've interviewed people that said, you know what? I've been experiencing that and I never told anybody. So I think that's what it is. I'm going to look into it. So I think it could be beneficial for your own well-being and also for the well-being of others to try to get over the stigma to talk about it.
I think that is one of the most important things that you can do in your role as a podcaster, is reducing the stigma surrounding sharing your story, but also sharing your personal story with your doctor and with others. And so even if you're not helping yourself directly, I think people do feel benefit from helping others.
Yeah, I've even spoken to some people and I was saying, even though you don't really have everything figured out, you still are struggling with this issue. You'll be surprised. Take a phone call from somebody else that is dealing with this, and just them being able to talk to you, or you may be able to identify with them in more ways than one, or be able to help them sometimes in ways you don't even know, because people need people and you never know what can happen when people start talking. And just finding someone that is out there that has this condition, I think is probably usually more helpful than not.
I agree. And I think the worst thing that can happen is they go to a provider and the doctor either doesn't know or says nothing can be done. And so helping educate the physician and provider population at large is also an important role for sharing these stories.
So, what do you think can be done medically or as far as research? What are some of the things that can maybe be done to possibly start bringing more awareness? I know this podcast, I know speaking about it like you on YouTube, but maybe even to try to have some pharmacological studies and stuff. Obviously, you need money, but what do you think can be done? Because some people are very frustrated that are connected to Charles Bonnet syndrome for the lack of awareness, the lack of treatments. And I'm just curious from a medical perspective, do you have any insight into that?
Yeah, so I think that the first step is education and awareness, but the second step, as you say, is a formal research into the underlying neurotransmitters and the biochemistry and the neurochemistry surrounding the Bonnet phenomenon. It's clearly some sort of release phenomenon where the loss of the vision releases the inhibition on another part of the brain. And I think that research can extend to other conditions with similar presumed pathogenic mechanisms. So increasing the awareness of it and removing the stigma of it are important first steps. And then the second steps is to find researchers who are interested in the underlying neurobiology of it. And because it has potential downstream impact on other similar conditions, funding that kind of research is really an important future goal. And I think that that is a secondary side effect of having awareness surrounding your podcast, finding people like yourself who have become passionate about the condition and raising awareness, but also perhaps raising funds to support the research of many of the people you've talked to on your other podcasts. I think that is also an important side benefit of getting the message out there.
So I know this could potentially be dangerous territory that I'm getting into because Dr. Dominic Fitch, who's like the world leader in Charles Bonnet syndrome, said that Charles Bonnet syndrome is a medical condition, not a mental condition. And I agree with that. But I do know that certain other conditions, if you have dyslexia, it's a possibility you may have dysgraphia, or if you have ADHD, it's a possibility you can have, I don't know, autism. Like it seems to be comorbidity sometimes with certain medical conditions. Maybe you can explain why that happens as a medical doctor, but it seems to be that some people with Charles Bonnet syndrome could potentially be dealing with some other things. I don't know if that's the fact that the Charles Bonnet syndrome wears you down so much that it causes anxiety, it causes other conditions, or that sometimes with medical conditions, there are other things that are present or manifest themselves. Do you have any insight into why that maybe happens in general, and then maybe any experiences that you can share anonymously about that?
So that phenomenon that you're describing is called a two-hit hypothesis, where you have one disorder, but you really don't get severe symptoms or signs unless you get this second hit. So comorbidities, where you have two conditions, make both conditions worse. So it's not just additive, it's synergistic in a negative way and makes both conditions worse. And so I think the role of identifying those comorbidities and treating those comorbidities is an important role of the physicians. And even though, as you noted, it is a medical condition, there are clearly psychiatric and psychologic aspects of the disorder that are worsening the symptoms. And so that is the role of proven pharmacologic therapy. So patients who have depression or anxiety and are made worse by their Charles Bonnet should still have traditional treatments for their comorbidities. And even if it won't cure the Bonnet, it fixes or at least mitigates the effects, the psychological effects of having the Charles Bonnet as a comorbidity.
Okay, I've heard some researchers, as a matter of fact, Dr. Gary Cusick, he's not necessarily a researcher, but he's a psychologist, and he leads a weekly support group for Charles Bonnet syndrome. He has said, among other people too, that they believe the way that people are going to be able to deal with the Charles Bonnet syndrome is like more of a holistic approach. You can't just take a pill. Maybe one day that will happen, but you may need talk therapy. You may need cognitive behavioral therapy. You may have to meet in a weekly group or get outside with a friend or whatever the case may be, instead of just being one thing. And it's amazing because like you said, some people have to start looking to the east and thinking about some other natural types of ways. It's good that there are different options and people can share what's working for them, but it can be a little bit frustrating to know that what works now may not work later, or what works for one may not work for others. But I think always keeping hope, realizing that it is what it is, the Charles Bonnet syndrome, and that it can harm you, and looking for what works and trying new things.
I agree with that sentiment completely. And so a holistic approach is really the bottom line on what you can offer to your audience, but also we offer to our patients. And finding the individualized but holistic approach and not having a one size fits all strategy is probably the best thing that can happen for a Charles Bonnet patient. We're just there to go on the journey with them, but we need the patient to be engaged in all aspects so that we can move from avoidance to adaptation and habituation.
So obviously you work at a large facility, or from what it seems to be, and you have staff and you have people that work with you. Do you do anything to make sure that the staff is aware of Charles Bonnet syndrome, and let them know if someone is presenting these symptoms or says this when you're writing in their chart, to maybe let them know about the condition, or let you know so you can let them know? I'm just curious, what are some of the precautions? Because I'm so grateful that you're aware of it, that you talk about it, you acknowledge it, but making sure that other people, the technicians, the nurses and everything, can be aware of that. What are some things that you can do, some tips that you can share for other doctors maybe to be able to deal with that?
So we have an illness script for a lot of our conditions that are common, and one of them is Charles Bonnet. So we have a script that we follow and that we share with the entire team so that everybody knows what words to use and what treatments are out there, and most importantly, the resources that are available to patients with the Bonnet, and now with the internet. And I'm sure you'll be happy to note we'll be adding your podcast to our list of resources for patients to access, as well as the support groups and the research work that's being done. And that by itself is empowering to patients who have come to us with the words, nothing can be done. So I think educating our allied health professionals, our medical students, our residents, and ourselves is an important part of Charles Bonnet for the patients at large, not just the individual patient. And then codifying that in something that the patient can take home, a tangible thing, is really helpful to them for their psychological well-being.
Thank you so much. If this podcast can help someone, that's really what I was intending to do. So certainly if you want to share it, I'm very grateful for that. And I like the fact what you said, because if someone has Charles Bonnet syndrome and you say, hey, there's nothing I can do, which I've actually had a neuro-ophthalmologist tell the person that I'm a caregiver for, and that was very frustrating. And I understand to a certain extent that's true, but it's not what you say, it's how you say it. And also what you say, maybe presenting and saying, hey, here's a podcast you can listen to, or Mary Carmel's Light. I'm going to interview them in a couple of weeks on the podcast. That's a new organization that was started here in America. And they specialize in Charles Bonnet syndrome awareness. And that's actually Eva Potts. She actually takes phone calls from people, and she participates in the weekly support groups, and she coordinates with a lot of people. And then they have, like you said, maybe from the show notes or maybe from research, Dr. Gary Cusick has a weekly support group for caregivers and the people with Charles Bonnet syndrome, because caregivers need the support too. And there's other groups and other places. So that means the world to me, and I'm sure to other people, when you can say, look, these are resources that are available. Reach out to them, listen to this, look, and hopefully that can make a difference, because it's really good to know that you're not alone, and it's good to hear people talking about things, and then you can identify with things. It's something about that. Just, I don't know what that is psychologically, but just realizing that somebody else can identify with you makes a difference.
I agree completely.
What are some kind of things that are on the horizon when you talk to your doctors and your friends, and I'm sure you go to conferences? Is there anything you're excited about? I mean, because one way that we know we can get rid of or diminish Charles Bonnet syndrome in people is to improve the eyesight. But the eyes is such a delicate organ, I'm going to call it. I don't know if that's the proper terminology, in the brain. And what I'm learning from speaking to so many medical professionals is you don't just see with your eyes, it's your brain and all sorts of things working together. But are there some treatments that are on the horizon maybe that could improve people's eyesight that you're excited and maybe want to share?
Yes. So, as you've alluded to, the major problem with Charles Bonnet is it's caused by vision loss. And in our country, in older patients, the most common cause of the Charles Bonnet syndrome is age related macular degeneration. And so, treating the root cause, vision loss, is the best hope for the future for Charles Bonnet by reducing the number of people who have significant vision loss. And low vision services, magnifiers, and the devices and the technology have improved so much that patients who had marginal vision, if they can just get a little bit of improvement in their vision, also seem to benefit in terms of their Charles Bonnet syndrome symptoms. And so there's a lot of hope on the pipeline for transplant and gene therapy and macular degeneration therapies for patients who have the most common blinding disorders. And so to reduce the number of Charles Bonnet people in the future, the best strategy is to reduce the number of people with vision loss. And so I think I am excited about the advances that are being made on all of those fronts.
That's exciting to hear. I'm glad to hear that. And what I'm realizing too is improving the quality of life of someone that has Charles Bonnet syndrome or someone that is visually impaired. It can actually help the Charles Bonnet syndrome. You may not be increasing the vision. You may not be getting rid of the Charles Bonnet syndrome, but if you're getting out more, that's known to help because isolation exacerbates Charles Bonnet syndrome. Or if you are talking to people or if you have new hobbies. As a matter of fact, on this podcast, I'm having a bit of a series of interviewing artists that are either blind or people that teach people that are blind how to do artwork. And I was telling someone on the most recent interview that I did, to me, that's a little bit of an oxymoron, being an artist or drawing and being blind. But we know that blind people can do anything that someone with sight can do, and they can even do it better at times. It's just about making the accommodations for them. And also, what I've learned too from guests is it's not how good your artwork looks or is. It's about the process of making it. And when you have these new hobbies and you have these new interests, and you start realizing, hey, I can do a lot. I think that can help with Charles Bonnet syndrome also.
Yes, that is exactly what we would be advocating. The two strategies that people use are number one, avoidance, and we're trying to avoid avoidance because, as you said, that leads to social isolation and worsening of the symptoms, and move towards adaptation and habituation. And the fastest way to adapt is to find a social group, to find a new hobby, and to learn to accept Charles Bonnet, but also that there are things more important in your quality of life that you should be focusing on. And over time, patients do habituate to the Charles Bonnet hallucination. But if you choose the avoidance strategy, you get isolated and don't leave the home and depressed. And so I think that is a very important thing that you just articulated, which is get out and improve your quality of life. And Charles Bonnet does not need to define you. You do not have to be defined by your disorder.
And also, instead of thinking, I can do that. Think about ways that you can do this. Maybe you can't get out now, but maybe you can get a guide dog. Maybe you can have a family member. Maybe there's an organization that could send someone to your house. There's always a possibility. I think that is really something that I'm learning too.
I agree.
I found you on YouTube doing research for Charles Bonnet syndrome, and I've seen a few videos of you discussing that. Do you want to tell people what your YouTube channel is and how they can maybe find you?
So our YouTube site is called Neuro-Ophthalmology with Dr. Andrew Lee, which is me. Its acronym is NODAL, NODAL, Neuro-Ophthalmology with Dr. Andy Lee. It's free. And so if any of your listeners have an interest in anything neuro-ophthalmic, not just Charles Bonnet, they are very short videos. They're informational, they're educational, and they're fast. And so I would welcome anybody to come on there. And if they want to have a YouTube made about a specific condition that they may or may not have, we're happy to try and make a YouTube that addresses whatever concerns our viewers are interested in. And it's called Nodal, and it's on YouTube.
I'm sure some listeners are going to go there and check that out and hopefully subscribe. And I really like the fact that you opened it up to say, hey, is there anything that you would like me to discuss? Really, neuro-ophthalmologists are the go-to for a condition like that because, correct me if I'm wrong, but you're dealing with eyesight and you're also dealing with the brain. Can you maybe discuss a little bit about what a neuro-ophthalmologist is, or maybe how they can potentially help people, maybe some other conditions that they treat, just a little bit of an insight into this type of doctor, because I wasn't aware of a neuro-ophthalmologist until about 2 years ago.
Yes, so neuro-ophthalmologists are at the intersection of eye conditions, ophthalmology conditions, and brain conditions, neurologic conditions. So we serve as a champion for disorders where the eye and the brain are interfacing, and the Charles Bonnet Syndrome is a perfect example of that interface. And so neuro-ophthalmologists often deal with brain tumors and strokes and aneurysms and multiple sclerosis and diseases that affect the brain where the symptoms manifest in the eye, and vice versa, where the person has an eye complaint or an eye problem, but really it's a manifestation of a neurologic or systemic disorder. And so that is the role of neuro-ophthalmologists, not just in the Charles Bonnet Syndrome, but in a whole host of related disorders of brain and eye. And so it's exciting for me to participate in this program because getting the word out about neuro-ophthalmology is also an important part of my job.
Hopefully, I'm not putting you on the spot here, but something just came into my mind. There was someone that told me that you can scan a brain and they said that it may look normal, but it may not function normally. That was really interesting because some people will say, I had a brain scan, so nothing's wrong with me, but maybe you're presenting some personality problems or some other issues. Do you have any insight into that, or is that more psychology? I'm just curious.
No, there are clearly limits to what our structural neuroimaging studies can see. And there are many conditions where the MRI, the CAT scan, cannot see anything. And so looks normal is not the same as is normal for brain function. And the Charles Bonnet is a good example of that. When we scan the brains of patients with Charles Bonnet, we see no structural abnormality. But we cannot see neurotransmitters. We cannot see electrical activity. We cannot see the release hallucination of the Charles Bonnet. And there are many neuro-ophthalmic conditions where the scan is normal, as you said, but the patient isn't normal.
This is really getting interesting. And I think about a book I was reading about ADHD, and it was Dr. Amen, and he actually is here in New York. And he was saying instead of like the 3 types of ADHD, which they say are like inattentive and hyperactive, and then a combination, he said it's like 11 or 12. And he said him and the people at his office, and they scan your brain and everything. So I actually spoke to another psychiatrist. This is a little off subject, but it's related to the mind. So I felt like sharing it. And he said he had a patient that came to him, and they actually went to Dr. Amen, and they brought all of these brain scans. And he was saying, and this is a board certified psychiatrist, and he said, it means nothing to me. And I said, that's interesting that you have 2 professionals who I think are both board certified. They both care. I believe positive intent. I believe every doctor wants to do the best. And they both have totally different disagreements, where one says the scans don't mean anything, and the other said the scans are very ideal. And actually, what you pointed out too, you can't see everything with the scan. So maybe that's what second opinions are. And I'm not trying to put you against one doctor, but I was just saying, I don't know if you have any insight into that, but that's interesting how different doctors feel about different things and how they come to different perspectives.
Yeah, I think that's a really important observation that you made. A normal brain scan gives doctors a false sense of security. That is a very common misperception, not just for neurologists or ophthalmologists, but all doctors. We get this overconfidence in our technology, and there are just some things we can't scan. And so a normal scan is helpful to exclude other things, but it's not helpful to say that the person doesn't have a real disease. And that's very bothersome that sometimes the patients, as you alluded to, get put into the psychology box because their scan is normal. And that's true in some cases, but not all.
Wow. So is there anything else that you would like to discuss? Feel free to mention anything that maybe we haven't gotten to at this point, because I know you're involved in a lot of things and you're very passionate and knowledgeable.
Well, I would just say to you and also your listeners, keep up the good fight. And Charles Bonnet is still under-recognized, under-diagnosed, and under-treated. And the work you're doing here, spreading the good word, getting awareness to increase, and improving the care and quality of life of people is why we all are doing this.